Okay, guys, so we're just going to pick up with the nutrition chapter and developmental needs. An infant typically doubles birth weight at 4 to 5 months and triples it at 1 year. Infants need about 100 to 120 milliliters per kilogram per day of fluid because a large portion of the total body weight is water. Now, breastfeeding is strongly recommended by the American Dietetic Association for the first 6 months of life, and they also recommend adding in foods while sustaining breastfeeding until 12 months. Breastfeeding offers multiple benefits for the mother and the baby. No regular cow's milk during the first year of life should be given. It is too concentrated for the infant's kidneys and can increase the risk of milk product allergies. Now, solid food from 4 to 11 months of life is important, especially with cereal. Cereal is an important source of protein. New foods should be introduced one at a time, 4 to 7 days apart. Toddlers need fewer kilocalories, but increased protein in relation to body weight. Milk is a poor source of iron, so it should not be given in place of other foods to toddlers. Toddlers do need to drink whole milk until the age of 2 to make sure there are enough fatty acids for the brain and neurological development. Now, I did say that new foods should be introduced one at a time, 4 to 7 days apart. Why do you think this would be so? The reason why you should introduce one at a time and about 4 to 7 days apart is to watch for any possible food allergies. Okay? Now, pregnancy occurring within the first 4 years of a menstrual cycle places the mom and the baby at risk because of anatomical and physiological immaturity. Not enough nutrients during pregnancy causes low birth weight in infants. Protein intake should increase to 60 grams a day throughout pregnancy. What is a complication of too much protein? Constipation. Pregnant women need folic acid. Folic acid is required for DNA synthesis and the growth of red blood cells. Folic acid helps to prevent neural tube defects. Now, moving on up to the adolescence age group. Adolescence is the most typical time for the onset of eating disorders to occur. Someone suffering from anorexia may exhibit intense fear, claims that they feel fat, and there'll also be an absence of 3 consecutive menstrual cycles for females. Now, what might you see in someone who has bulimia? Binge eating, vomiting or laxative intake, and going to the bathroom after eating. Now, moving on up to our adults over the age of 65. Now, do they need less or more energy for their metabolic rate? They need less because their metabolic rate slows, but they still need just as much vitamins and minerals as they were intaking during middle adulthood. Now, older adults, senses fade, so they may not want to eat. Maybe they can't taste their food. Maybe it doesn't taste right. Or older adults could have broken or missing teeth. Maybe they are using dentures and they've lost or gained weight. Whenever you lose or gain weight, it's possible for the dentures not to fit properly, and sometimes sores can develop in the mouth from this. Many aging adults also live on fixed incomes, and they can't always buy what they need, or maybe they can't get to the store to get what they need. Okay, now dehydration is very common in older adults. What are some symptoms that you would think you might see with dehydration in an older adult? Confusion, weakness. They might be warm to touch or hot, dry skin, furrowed tongue, rapid pulse, and a high urinary sodium. Now on page 1006, there's a table of religious dietary restrictions. I do want you to read over that table, please. Malnutrition is unintentional weight loss. With malnutrition, oftentimes there's nausea, vomiting, diarrhea, sometimes even constipation. Now, there are different screening tools used to help identify malnutrition. Now, when we talk about BMI, BMI is our body mass index. To calculate a BMI, we would divide the patient's weight by their height in meters squared. A BMI considered to be overweight would be 25 to 30, and over 30 would be considered obesity. Dysphagia is difficulty swallowing. A complication of dysphagia, a few could be aspiration pneumonia, dehydration, and a decreased nutrients, or weight loss. Now, there are 4 types of dysphagia. We have myogenic, which an example would be muscular dystrophy. We have neurogenic. An example of neurogenic dysphagia would be a stroke. An example of obstructive dysphagia would be tumor. And then there's a category considered other, and rheumatological disorders would fall into the other category. Now, we need to feed patients with dysphagia very slowly. We need to allow them time to eat. We also want to make sure we are using the correctly ordered liquid for that patient. Thin liquids, is it nectar-like? Is it honey-like liquids, or spoon-thick liquids? Okay. Now on page 1011, there's a table with signs of good nutrition versus signs of poor nutrition. Be able to distinguish those. Now, how would you teach a patient food safety? We want to make sure they're washing their hands, they're rinsing their fruits, rinsing raw meats, washing cutting boards and cooking utensils, using food thermometers, and not saving leftovers for more than 2 days. If someone has chemotherapy, or if someone is currently undergoing treatment with chemotherapy, and they have mouth sores and a decreased appetite due to nausea, how can you, as a nurse, help these patients? Whenever you take their food tray into their room, you could maybe take the lid off of the food tray at the door, so you're not taking the lid off right in front of them. Sometimes a strong food aroma can upset their stomach. You could help them order foods that will be soothing to their mouth. And you could also recommend to the doctor that you think that they might benefit from an appetite stimulant. Now, there's a list of diets on page 1017 that will be good to familiarize yourself with. Now, if a patient has trouble seeing and you didn't have time to help them, you can tell them where each of the items are using the clock format, and you can also check on them frequently. Now, you want to introduce yourself in a calm manner, and don't touch them without telling them. I'm going to go ahead and keep going. We just have a little bit more left here. Now, on page 1019, there's a list of enteral and parenteral nutrition and which disease processes would be an indication for each of the different types of nutrition, okay? Now, enteral tube feedings provide nutrients into the GI tract. These are for patients who cannot take something orally and they have a functional GI tract. Enteral tube feedings typically consist of NG or nasogastric tubes, jejunum, and gastric tubes. What would be a sign that a patient is not tolerating feedings? The patient might experience nausea, vomiting, cramping, or diarrhea. Now, aspiration is oftentimes a risk that can be present with enteral tube feedings. Coughing, gastroesophageal reflux disease or GERD, suctioning, and a decreased level of consciousness can all be factors that allow aspiration to be even a larger risk for patients with enteral tube feedings. Now, patients that oftentimes suffer from GERD, jejunal feedings are the preferred method for them. Now, with feedings, should the bed be flat? No, it should be 30 to 45 degrees. Now, keep in mind that patients that are getting enteral tube feedings, they're at risk for aspiration. With aspiration, the patient can get pneumonia and infection. Okay, tube feedings are typically high glucose concentrated, so that provides a medium for bacterial growth. Now, let's say that a patient is going to have enteral feedings for more than 4 weeks. What type of enteral tube should they have? A surgically or endoscopically placed tube. This will reduce comfort, and also these tubes are more secure than a nasogastric tube. Now, parenteral nutrition is when nutrients are given intravenously. We have PN or PPN, which is peripheral parenteral nutrition. It's a basic formula that consists of amino acids, hypertonic dextrose, electrolytes, vitamins, and trace elements. Now we have TPN as well. TPN is total parenteral nutrition. Now it's a 2-in-1. Fat emulsions are administered separately from the protein and dextrose. So if you have a patient on TPN, you'll be hanging lipids separately. They look a little bit like a milk. Now, it's important that if your TPN is being filtered, that you connect the lipids to the port below that filter, okay? Now, and TPN has to be given through a central line. Why would you check a blood sugar if a patient is getting nutrition intravenously? Because it is a dextrose solution, and also some bags contain insulin, depending on your patient. Now, on pages 1022 and 1023, there's a great reference for complications related to enteral and parenteral tube feedings, enteral tube feedings and parenteral nutrition. And then read for yourself pages 1024 to 1025 to look over medical nutrition therapy and certain disease processes. I will see you all next week.